then I'm going to just share with you some resources and then kind of go through a PowerPoint slide from our colleagues at New Hampshire, ECHO, and kind of how they're coordinating kind of statewide services for our kids in school with behavioral health concerns. So the case I think occurred last week sometime. We've all been on calls so often we just forget, day to day what's happening. But I think this happened last week, and a youth from very rural neighbor island went to this is an elementary school youth, and went to the school counselor and let them know that their levels of distress and anxiety and depression were increasing to the point where they were feeling they could not control the thoughts and the urges any longer. So the school staff, the classroom staff, actually walked the youth to the school counselor, and which is remarkable in our neighbor island communities, that they're so creative and so resourceful. They had already established a behavioral support plan for this youth and a crisis intervention plan within the campus. And I'm finding this is a lot more consistent with small neighbor island community schools to really provide a network of support within the school community and actively involving the students, but the families on a regular basis. So the youth told the counselor, I'm really distressed, I'm anxious, and I'm just having these thoughts of wanting to hurt myself. And the counselor kind of was aware of all the programming that they had for the youth. So they recommended that the youth actually be brought to the emergency department by the family and then have a safety assessment done. And in the meantime, the counselor activated a crisis mobile outreach staff. And what's interesting is that crisis mobile outreach, which is statewide, had been integrated in this school's programming for crisis intervention and behavioral supports. And so they knew the parameters of the program. They may have known the youth from previous encounters, but they actually went to the emergency room, met with the youth and the family, and worked really closely with the ED physician and staff. And actually, what the crisis mobile outreach, staff provider did is they engaged with the family and the youth, realized that the distress did not warrant an emergency or emergency hospitalization or acute hospitalization at Queens. And just to let everybody know, I think as of October of 2024, I think the only acute hospitalization we have for our youth is at Queens Medical Center or the Family Treatment Center on Oahu. And of course, this emergency room was far from there. And they did an emergency assessment, a safety assessment, walked through safety planning, and the family was very comfortable having their child returned home to them, and they would follow up with the school behavioral services the following day. But also the crisis mobile outreach staff person also was able to align the family with a broader access to community-based resources. So the family was very appreciative of the support and services. The emergency room physician and the staff were very encouraged that they had access to these resources in the emergency room. And it wasn't a long time before they arrived. And I think it was because the counselor at school was able to mobilize this resource the moment she saw the youth. I kind of showed up really kind of late in this process, only because if there was an indication for hospitalization, then Queens could be engaged in the process pretty immediately and try to arrange transportation and services for acute hospitalization at that point. But the next day, I was really surprised that the staff and the emergency room physician followed up with the family, had a contact, phone call, engaged with the family, found out that the youth was doing well, re-engaged with the school, and also was engaging with some of the broader array of community resources. She reviewed the planning, the safety planning, and the treatment recommendations. And the family was, again, very appreciative of that follow-up. So kind of with this case, I just kind of wanted just to kind of bring to your attention that this is very rural Neighbor Island, kind of late in the day, late in the school day. By the time I arrived through telehealth, it was probably, later in the evening. So the youth and the family had been in the emergency room well over 5 or 6 hours. And you can kind of get a sense of how stressful that could be for a family, or especially for a student who's pretty distressed already from the activities earlier in the day. So what I'm going to do now is share my screen and kind of provide for you updates on the local resources we have. And much of it is from our colleagues at Child and Adolescent Mental Health Division through the Department of Health. And we were talking about kind of the challenges we've all faced and our families have faced from the pandemic, but we still face these challenges, especially in rural communities and access to behavioral health resources. But I did want to highlight this school in particular that already had taken advantage of available resources at the time, making adjustments as those resources change over time based on budgeting and staffing. And all of you are well aware of programs closing and opening. And so that's why I was hopeful that I could share some updated information for you. So I'm going to share my screen. And Char, can you see this?
Yep, but we can
You
see it.
can.
What
The
you
CAMHD
You're on
website.
CAMHD. Yep, that's what we see.
Perfect. Perfect. And you know what I did? I forgot to do the video. Give me a second. So I'm going to share it again. Optimize video. Okay. So this is the kind of the starting point for CAMHD, the resources, the online application. This has all kind of been developed since the pandemic and actually broadened, and it's been enriched. Their application for services is now online, and you could just go to that website. And I'm also going to provide Shar with a list of resources, and all of this is on there. So you'll have it at your fingertips. But if you just kind of go for wherever the family is and wherever this may be, and I can tell you a story in a second, but you can just check the island, and then you can just click that highlighted area. And then all of a sudden, this application pops up, and it's specific for the Family Guidance Center that you just selected, which is the Home Family Guidance Center for the family. And what happened during the pandemic when many of our children were boarded in emergency rooms for days and weeks, the collaboration between CAMHD and Queens and the University of Hawaii developed a bridge program where children who are being discharged out of the emergency room at Queens and other emergency rooms across the state, or the family treatment center or the acute inpatient, were then followed in a bridge support service where many times we were using this application with the families as they were being discharged or as they were seen in the emergency room. And then that engaged the registration and eligibility determination for this family with services from CAMHD. And many times CAMHD had asked for documentation to support the application process and to help the staff at CAMHD for eligibility, which was incredibly helpful. In other ways that the bridge support, and the bridge program was developed by Dr. Humphrey, who's the medical director at CAMHD, and Dr. Barry Carlton, who was He is still the Director of Medical Education and Patient Care at our Queens Counseling Services. And of course, Dr. Guerrero, who's our chair for the department. And so this was developed, I think, in 2020, and it still continues because just the number of children who are discharged out of acute hospitalization or emergency room assessments going into community-based levels of care. And this helps expedite that process. And then let me just go to the next one. So the next page of the resource in CAMHD is a list of all of their services. And I would just encourage you just to kind of scroll through this. And I learn something new every time I go here. And I try to do it every several months or so just to get updated on access to services. They have services for our gender diverse and our sexual preference diverse families and children. I think I'll go to that next. And this is just a resource that is still being updated. Like you can see here for Oahu, the Lavender Clinic, of course, is no longer available. But I do hear from a lot of behavioral health folks in this community that they're looking at starting up these programs that have recently closed. There are other resources across the state, as well as identified resources for each of the islands. And that's another resource. And then there's their acute services. And then if I can go here. So here's the suicide prevention resources. And in there's these embedded videos. And one that I'm delighted to share with you is from our own professor of the department, Dr. Deb Gabert, and she did a suicide support presentation to KHON, I think a couple of years ago. So I'm going to share that with you now.
Well, suicide is a devastating subject that we deal with in our society all the time, but it's particularly heartbreaking when it involves our youth. There are ways to help with this problem, and joining us this morning to talk about how we can do just that is Dr. Deborah Gabert. Deborah is the co-chair with the Prevent Suicide Hawaii Task Force. Good morning, Deborah. We really appreciate you coming on this morning to talk about this very important issue. What's the biggest misconception about youth suicide?
I think in general, the biggest thing that people consider is that if you talk about it, you're going to plant that idea into somebody's head. And so we really want people to know that by talking about it, that's the only way that we can get people to help. So we have to talk about suicide. It is not going to give anybody ideas.
I didn't even think of that when I was reading the notes before this show. I'm like, I didn't even think of that misconception. I thought, well, they wouldn't want to talk to you. They're just going to yell at you for trying to talk to them, something like that. But that's very interesting that people would think like that. Interesting. So how can parents talk to their kids about suicide? How do you go about that?
So what we really want to do is set up routines. So if you set up a regular place to talk, then that puts in place a time, a space, and you're not dealing with it like all of a sudden being attacked because you think something's going on.
Right.
So one of our best strategies, and I always laugh at the science that we do, but it's having a meal together. So if you have a meal and you sit down and you share, and it doesn't have to be dinner, it doesn't have to be fancy, it doesn't have to be any of those things. If you just set a regular time to meet and talk, and usually over food, it just makes it easier. And then that allows those conversations to happen when they're needed.
And not talk about the hard-hitting subject all the time.
No,
just somewhere where it's a routine to talk. And oh, by the way, is a lot easier to go into something. Yeah, because
exactly. And with teens, it's a little harder. Their schedules are so busy. So even a snack.
Yeah. Put the cell phone down. We're actually going to eat a meal and talk to each other.
4 times a week.
4 times a week. Can we go for 3? No bargaining. My dad, we wouldn't even ask my dad. So what if they don't want to talk? What do you do then?
Yeah, so we do know that 85% of youth are telling someone. So they do want to talk. They do want to share it. Sometimes they put it out there and you think they're joking or they're just testing waters, but it doesn't have to be you as a parent.
God forbid if they're just testing waters. That could just...
It's the same thing, exactly.
Yeah.
So kids tell us, grandma, uncle, right? coach, clergy. It could be a counselor, right? It's whoever they feel comfortable with. It doesn't matter what adult they're talking to. We just want them to talk to an adult.
Probably who they're most comfortable with. And typically that's not mom and dad. I mean, hopefully it is if you have a meal four times a week.
Can be.
Right? Yeah.
And if there's no one for them to talk to, we have numbers to call. So they can call 988. They can text 741-741. And that's a lot more comfortable. Sometimes that unknown makes that an easier
and these are professionals on the line that know exactly what they're doing. They're trained to take care of this thing all the time. That's a good point. So do you recommend resources for parents to help?
Yeah, so there's some great resources online. Seize the Awkward is intended for kind of young adults talking to young adults, but it gets you a feel for how the conversation might go.
Yeah.
The American Foundation for Suicide Prevention has a new program called Talk Out the Dark.
Yeah.
And it just gives you conversation starters, because that's a hard thing, right? Like, where do I go with this? But it's actually quite simple. You know, you're really just starting with, I'm concerned about you and I care about you.
Yeah.
But there's lots of stuff online for that. Of course, Hawaii Cares is one of our great local resources, and they have more and more information every day, and they operate the local 988 number here.
988. If you don't get anything out of this, get 988. That's key. And set a routine for the kids. If you don't already have one, a lot of people here in Hawaii already have that, but if you don't, get it started. So it's routine. You can talk about it. Deborah, thanks.
Yeah, my pleasure. Thank you.
Really appreciate your time. Coming up on Take Two.
Take Two.
Well, suicide.
Thank you. Thanks to Dr. Gaber. Okay, so I'm going to now kind of close this and start up the PowerPoint. Char, can you see the PowerPoint?
Yep, we can see it.
You can. Okay, great. Thanks. Oh, and I forgot as I left the other screen, I will also include the access or contact information for crisis mobile outreach, and that is a statewide network program for families and communities across the state. And so there's individual island access as well as the general access. And what I'm just just amazed at is their ability to provide access into the home and be available for helping families and children with safety assessments in the home. And as I had mentioned with the case, that they had already been involved and as an integral part of the behavioral support safety planning and the crisis management planning for this very rural neighbor island school. So today we're going to be talking about keeping our students safe. This was an echo presented last year from our colleagues at Dartmouth and New Hampshire, and just focusing on identifying students in distress and how coordinated programming can occur. And I think much of this nationwide effort really had grown as a result of the pandemic. Okay, so let me just go in. Okay, so some of the things to be thinking about: recognizing signs of serious distress in students, identifying key sources of that stress, recommending supports, resources, strategies to effectively address those areas of distress, and then improving the school settings and environments, improving the partnership, those stressors, as well as intervening at critical points for our children. So this PowerPoint presentation, I think, has 5 sections. I think we'll have enough time maybe to cover the first, definitely part of the second one. So the first one is recognizing and responding to students in serious risk of harm. The second presentation is understanding the inpatient psychiatric hospitalization, and really important, the return to learning process. And session 3 is recognizing and responding to students in distress. And the 4th presentation is improving school partnerships with community mental health and primary care services. And the 5th session is partnering with the families. You will all have access to this whole series of presentations, so you can review it, the whole one in total, at your leisure. If we don't have time today, maybe I'll have an opportunity in the future to go over the last parts that we don't get to cover today. So the first one is going to be presented by our colleagues at New Hampshire ECHO, Julie Balaban and Mark Bellinger. It's recognizing and responding to students at serious risk of harm. Their presentation really is trying to bring to our attention the growing needs within our youth, that anxiety and depression, thoughts of suicide are rising, the levels of acting out, disengaging with peers, social activities, isolating themselves is increasing. We're seeing a lot more parental challenges with stress, mental health, substance misuse. When we're talking about consequences of the pandemic, I think we're seeing this continuing, and I'm just grateful for the collaborative efforts in the community to address each of these things in a collaborative effort. Very few programs can do this alone. And of course, the unhealthy use of online access and social media. In conjunction, we're also seeing a significant reduction in resources, the availability of providers and therapists, which means long wait lines, wait lists, even for remote access to behavioral health services. There's long wait lists and decrease in availability, and also a decrease in the availability of crisis beds, which had during the pandemic, led to enormous amounts of time of children and families waiting in emergency rooms, waiting for those crisis beds. We're not seeing the wait times as great as they were during the pandemic and shortly after post-pandemic. But sometimes, we do see some families waiting in the emergency room for extended periods of time. And like I said before, since October of 2024, Queens had purchased Kahi'imohala, which had both an acute inpatient, as well as a residential inpatient programming run by Sutter Health out in Kahi'imohala, which is out in Waipahu, real close to Queens Medical Center West. And just looking at the levels of risk, this presentation was developed just about a year ago. So at that point, 40% of the high school students had reported significant psychiatric symptoms. Suicide is now the second leading cause of death for our adolescents 15 through 19 years old. And some of the New Hampshire data, and I don't know how far off we are with the Hawaii data, but some of the New Hampshire identifies a little over 20% of our students had a serious plan about how they would complete suicide or end their life by suicide in the previous 12 months. 10% of those students actually attempted suicide at one time. During that time, some of the vulnerable groups, such as our Black, Indigenous, and people of color, were over 10 times at risk compared to our white youth. Our gender diverse youth were 4 times the risk than our heterosexual cisgender peers for suicide attempts. And I think the data from New Hampshire, I think in their 2022 screening, so this is probably in the middle of the pandemic, showed that 20% of the teens ages 15 through 18 had answered yes to the questions: do you think you may be gay, lesbian, bisexual, and transgender? Fixed risk factors for suicidal ideation is a history and presence of psychiatric illness, family history of depression or suicide attempts, or death by suicide, loss of a parent. So this is kind of addressing some of the childhood adverse experiences. And so loss of parent through death or divorce, abuse history, physical, sexual, and emotional. Some of the gender differences: men are 2 to 3 times more likely to die, while women are 3 to 9 times more likely to attempt suicide. Also, a significant risk is belonging to a high-risk vulnerable group. Examples of those that we just described. History of past suicide attempt is a significant risk factor, and exposure to suicide behavior and others. And I'm just beginning to understand social media and some of the online access to some of these groups that some of the children describe that they have access to, and how they are able to make comments of their own experiences, but also learning about the experiences of others, which is also problematic sometimes. And this is also an opportunity to intervene with the family to provide safe protections around access to social media for our kids, especially our younger kids. Some changeable risk factors: lack of support networks, social isolation, active bullying and abuse, access to means such as guns in the house, medications, poisons, access to sharps and knives and things like that, and then substance use disorders for the children or the family. So in assessing children at risk for suicide and danger, and I think this is what I learned from this community school and effort, was to err really on the side of caution when assessing the risk. It was interesting that the crisis mobile outreach staff had immediate supervision with their own support staff. And I believe a psychologist is involved in providing direct supervision for every single case across the state. So don't put yourself in a situation where you're not equipped to manage, knowing where your support systems are when you're assessing risk, and kind of know the systems process for managing safety, and then know who you can consult with and refer for the next steps and for more help. And I think that's what the school had been doing previously, and including the crisis mobile outreach program into their behavioral support network and their crisis management program. So how do clinicians think about risk and harm? Is understanding the ideation and the intent, identify whether the youth has been actually considering ways in which they would end their life and starting to plan. Do they have access to means? And that's why it's critically important in the safety planning when discharging from inpatient hospitalization or the emergency room, or at any time, even in just a regular outpatient intervention or an appointment, is really to assess safety, access to these risks at home when they leave, and then also assessing their risk factors, and then assessing the protective factors also. And this is, again, some of the questions that can be asked to assess the level of suicide. And this is what happened in the emergency room when the counselor met with the student initially in the case, and then decided that when the youth said their distress was elevated to a point where it may not have been before, then the counselor then went to the next level of support, and that was to have the youth taken to the emergency room for safety assessment But it's also important to know, again, when passive ideation then starts changing to more active and preparatory and planning behavior. Self-harm, or is it self-harm thoughts and ideations, or is it suicidal thoughts? And again, for those youth involved in non-suicidal self-harm, which can be frequently cutting, sometimes burning, many times scratching, that's also a risk factor for suicide in the future. So those are a significant concern and risk factor. Strength of the thought and the wish, it's always important to ask. The CSRSS, I think, is the Columbia Suicide Risk Assessment Scale, and they'll ask through a number of levels, and then also how powerful and frequent are those thoughts, and how much control do you have over those thoughts? How do you ask? What kind of thoughts are you having? Do you have thoughts of wishing to be dead, or I'd be better off if you were not around, or if you've never been born, or if you wouldn't? These are all about thoughts they've been having. And then again, in regarding to assessing plan and intent, is have you had thoughts about what you might do? And then, what is the closest you've come to those thoughts? Have you ever done this before, which are all significant risks for suicide? And what's kept you from acting out on these thoughts? What have been the protective factors that you found helpful in the past? And how hard is it not to follow through with these impulses or thoughts? So kind of demystifying the talk about suicide. And this is what Dr. Gabert was sharing in her video clip, is being willing to reach out and talk, providing opportunities within the family dynamic and structure. And also importantly is where the kids are most of their days at school. So many very proactive schools are developing kind of a destigmatizing opportunities and programming and activities where the kids can all be together and have a chance to talk about some of the serious things that they experience, and how to kind of mobilize access when they're feeling distressed. And whether the stress comes from home, or if it's coming from academic challenges, or if it's coming from interpersonal relationships at school, is really having the staff and the trusted adults as barometers within the school to allow the students to engage with those resources at any time. So that means with a behavioral support plan or a crisis management plan, like with this youth at this neighbor island school, they knew that they reached a level of distress. They notified their teacher. The teacher walked the youth to the counselor, and then the sequence of events occurred from there. The student was very familiar on how to activate the sequence. The family was very familiar because they've had rehearsed this before. They probably have gone through it before. And then, of course, crisis mobile outreach, which then engaged with the family in the emergency room, was activated from the school. And they are also very actively involved in developing programs for kids. Okay, so willing to talk about it, language and tools, feeling qualified. And I just wanted to remind you too that Dr. Gabert talked about in her presentation is training resources for those who are involved in providing these emergency assessments for kids, but also resources for families to find safe places, kind of a routine encounters like having dinners together, and allowing that level of discussion to occur at the family level. And also having a therapist involved can be very instrumental and helpful for engaging these families in discussing this, but also to start preparing and providing safety nets around the youth and around the family. At the school, following the organization's rules and policies, but you're never doing it alone. There are many, many resources, and that's why I think it was important to share these resources with the group today, because these are these resources that you can share with your families. And again, as Dr. Gabert said, talking about suicide does not cause kids to think about suicide. Okay, so kind of some means as we talked about, the males being significantly more in the process of ending their lives by suicide. The girls will attempt more, but the males will be more able to end their lives by suicide. And then, of course, the mitigating or protective factors, cultural and religious beliefs will be an integral part of supporting the family and aligning with their community resources, personal connections with family and community and friends, supportive relationships with caregivers, available healthcare. And again, since the pandemic, we know telehealth has always been part of kind of the community continuity behavioral health access. But since the pandemic, it's been a lot more accessible and resourceful. But I also find out that many of our neighbor island families really don't care for remote or online access. Sometimes it's okay for an emergency assessment, things like that, but they do prefer in person. And that's why it was important for this neighbor island community with this youth is to engage them in the available community resources. And which was great is the crisis mobile outreach staff member was very familiar with the resources in that community and was able to align this family with resources the next day. And that's what the emergency room physician found out after making contact with them after they left the emergency room. Okay. So safety planning, identifying the risk and protective factors, securing the means of safety within the home. Interesting, though, this one in securing means, especially with medications, sometimes families will secure the youth's medications, but there really isn't security around family members' medications. And so it's often, many times, we're seeing the youth having access to a grandparent's medications or a parent's medications and causing significant injury. So thinking about comprehensive access is really important. Identifying trusted, responsible adults. And many times at school, it might be a community of adults that the child or the youth has access to and knows who to contact. Decreasing the
Dan?
triggers. Yep.
Got a good question here. Renata asked, at what point do you, and I might have missed the right place to ask this, at what point do you instead ask, what do you have to live for to help the individual stop the negative self-talk? And that sounds kind of like, to switch the conversation to that.
Yes.
Positive.
And that's, yeah, absolutely. So yeah, Renata's question really is shifting the distress and despair into what are the very positive coping mechanisms that the youth may have begun to start working on with CBT or dialectic behavioral therapy, but the youth may need help and assistance in shifting into some of those protective skills and coping mechanisms that they may have learned or they may be learning just in this moment. So absolutely.
Yeah, finding even a shred of motivation to live. And it sounds kind of like motivational interviewing reversed,
Yes.
talking about the negative, you talk about, well, actually kind of like motivational interviewing. Yeah. I don't know if this is the right place to ask because you might talk about it, but my question is, how much help have you seen youth mental health first aid or mental health first aid provide?
Quite a bit. And especially for Maui, who are still in recovery from, our wildfire crisis. So mental health first aid, crisis first aid has been a significant part of not only Maui's recovery, but for the behavioral health efforts across this state.
That's it. Sorry, go on.
Oh, that's it.
No more.
I'm trying to read through the comments. Okay. let's see. So safety planning. So security means decreasing triggers. This really is comprehensively trying to get a sense of how can the youth return into their environment with different access to more resources if necessary, which is really important. And we may not have a chance to discuss this, but this might be in one of the other sections. But really, when you return to learn out of the emergency room or out of inpatient hospitalization, whether it's acute or residential, the return to learn is a really significant part of that process. And it really is trying to find out what those positive aspects are for that youth, which may not have existed before, or it may have existed but needs to be broadened. And those are things to be familiar with and to spend time with. And steps to take if the thoughts and the urges they occur, and they'll always occur. And I think with the safety planning is trying to find out, what is it about the night or being alone or getting ready for sleep when the intrusive thoughts become overwhelming and you feel that you're absolutely powerless in trying to manage them. And this is really a challenge for families. And this is also significant for our kids in the hospital. They may be doing great during the day with activities and learning skills and being involved in group activities. But when they get ready for bed at night, when they're alone, it's really challenging for those kids. And then also plan for monitoring and follow-up. And let's see. So we may have chances. We're at 15 more minutes. I may just go 5 more minutes into the next section. But just as a reminder, the warning signs for suicide for kids, talking about being a burden, isolating themselves, increased anxiety, worries, apprehensions, fears, talking about being trapped, the unbearable pain, the distress, as this youth shared this distress with their school staff. Substance use, we didn't talk about it at all today, but of course, the role of vaping, especially vaping cannabis and edibles and access to these can cause quite a bit of distress for our kids, and they don't have to be using it for very long before their levels of paranoia and anxiety and depression just start to escalate and become out of control. Very worrisome psychosis occurs with our kids, especially if they have any genetic vulnerability. Looking at ways when the youth is looking for ways to access, they may be storing or hoarding their medications, or actually accessing medications from family members within the home, accessing their friends' medications. These are things to be thinking about. When there's increased behavioral anger and rage, extreme mood swings, expressing hopelessness, sleeping more than normal or less than normal, and then talking or posturing about wanting to die and making plans for suicide. So these are all the CDC's warning signs. And let's see. Now, these are the resources for New Hampshire. We talked about the resources, and Dr. Gabert presented the resources for Hawaii, which are great. And then I think in the next few minutes, I do want to, just because it's reflective of what's happening here in Hawaii and the role of Kahimohala now, I do want to look at the understanding inpatient psychiatric hospitalization and the return to learning. So let me just.
And you said Kahimohala was bought by Queens?
So Queens purchased Kahimohala in October of 2024. Historically, before that, for the past 4 decades or more, Sutter Health has been managing Kahimohala, and they had both, of course, the inpatient acute and their residential programming out there. They also had partial hospitalization and intensive outpatient programming. But as of October, all the acute services, and I'll just kind of show you pictures here. So all the acute services, so this is New Hampshire, but I'm just going to have you use your mind's eye and think about Waipahu right now, which is really nice because it's like 14 acres out there. grasslands, and there's a ropes course, and there's outdoor facilities for pool and recreation and basketball and pickleball and all the things that all the kids really enjoy. Because when the kids come to the Family Treatment Center at Queens, they say, I think I'd rather be out at Kahimahala. And they're absolutely right, because being at the Family Treatment Center at Queens in Honolulu at Punch Bowl is very different. They're renovating a lot of programs. I think they had 44 beds or more identified for kids. Right now, they're probably using 20 or 30 beds for residential only. They're remodeling the other two buildings, which will bring them back to their capacity of 60 or 70 beds, but they're not there yet. We have a capacity for 16 beds, I believe, in our acute unit here at Queens. But I did want to just say, Kelly, I don't know if that answered your question regarding Kahimahala. Okay, so again, now as of October, our acute inpatient is here at Queens Family Treatment Center. Kahimahala is now Queens Kahimahala, and that is residential programming. We also have Queens Partial Hospitalization Program, and that is where the youth attend every single day, education, school included, and that is they spend in programming. And they could be referred directly to the partial hospitalization program, or they could be referred from the Family Treatment Center or the ED. And that is spending the day in programming, and at night they go home. And then we also have the intensive outpatient program, which is, I believe, 2 to 3 afternoons, late afternoons through the evening of intensive programming. But that's kind of dependent upon staffing and budget. So I don't know if that is ongoing right now. But again, the constellation of services between acute and residential includes, all the diagnostic clarification, coordination with care teams. It says occasionally schools, but I think for us, we primarily are using community-based school support and working with the schools, even when the child, the youth, is in hospital-based levels of care. And of course, the treatment is crisis stabilization, adjusting medications if there are. It's not always medications involved, but also engaging the family and the kids in CBT skills. And hospitalization, some of the details, acute hospitalization could be from days to 2 weeks. Many of the kids then transition into residential-based care, which could be from days, weeks to months, which allows us additional resources, especially if the children are engaged at residential level of care. Then the school has already been engaged, and they're involved in educational programming, and it's that educational programming that aligns with the youth as they return back into their community, and so they can re-engage in the school. And then the child will be discharged with weeks of medication and follow-up with the outpatient setting and discharge summaries. That also is significant for the bridge support we had during the pandemic and still do. And that means that as kids discharge out of all levels of hospital care, sometimes, it may take some time before they get reintegrated or integrated into community level services. So many times their medications will run out before they engaged in outpatient care. So our bridge program will then make sure we follow these kids statewide through telehealth or face-to-face and make sure that they don't run out of medication, that documentation and discharge summaries, which will allow CAMHD, especially the youth and families who are applying for services, and as CAMHD reviews eligibility to determine whether they receive services or not, our documentation, discharge summaries can help in that and expedite that process. So the bridge program, which actually started during the pandemic, is still going strong. And I want to thank the fellows and the residents for their contribution to that. I did want to say one thing, maybe we have just a few minutes left. Return to learn. This is a really significant concept. let's see. Renata asked, do youth have access to their chart online? Great question, Renata. I think the families definitely have access, and the youth at a certain age will have access, especially the youth 15, I think, will have access, but there's also access to the charting that is not allowed, and that's determined by the team in discussion with the families. But I don't know if that answered your question. Renata, if you have any further comments, please just put it in the chat. I'm trying to make sure I look at the chat. So Return to Learn, this protocol was developed for kids with concussion. And I just wanted to say, we have a lot of children who are experiencing sports-related concussions, and they're out of school for a very, very long time. But I'm also wanted just to bring to your attention just the number of traumatic brain injury that's not only sports related, but other accidents and injuries. And what I'm seeing more often now is the injuries related to e-bike and e-scooter and e-skateboard. And these children are unhelmeted and they're very, very young. And so they've got a long process to re-engage into school and recovery. So the Return to Learn is really kind of a program, kind of a guideline, and it has a number of stages. But what's interesting about the stages is this is for brain injury and how to reintegrate the student back into the classroom and following these guidelines. And having the family and the care providers and the rehabilitation team and the child and the neurology team and the neurosurgery team working closely together with the school to determine how to reintegrate the youth most appropriately and to identify areas where they may be moving too fast. And so this is where the behavioral health team and the medical team can engage with the teams in the community to provide the monitoring and the feedback, and especially if it's an IEP meeting or a 504 reintegration meeting, this is where the team can work very closely. And I'm getting a sense that the fellows are finding this to be a very rich learning experience and helping the school teams and the families reintegrate their youth back into the school system. But the reason I brought up the traumatic brain injury, and we're seeing so much more of it with our activities, but for all behavioral health related issues too. So even kids who are being discharged out of the emergency room and inpatient hospitalization need a return to learn programming. And that's where the behavioral health team works very closely with the PCPs and the family and the community school system to make sure that the support network is established. The IEP team or the 504 team is meeting regularly. They're monitoring progress, but they're also meeting as a team to discuss benchmarks and progress and to make adjustments in real time. So Kelly, I think we have 2 minutes left. I'm just going to stop.
All right. I didn't see
not
any
enough
cases.
psych beds. I just saw one from Ella.
Yeah.
That's the one. Yeah, not enough. Absolutely. So I think that's what the goal is for Kahimohala, is to get those 2 extra buildings renovated. I think there's quite a bit of work that's being done, but it started already. And within the next year, I think they're going to have a full complement of over 50 or 60 beds for kids. So we're moving in the right direction.